Okay, good afternoon, everyone. Welcome to the Winter Communicable Disease Forum. My name is Kim Cervantes. I'm with the Communicable Disease Service. If someone could type into the chat box if you can hear me, I would really appreciate that before I speak too much. Can anyone hear me? Do you have a? Oh, call it. See if you can hear. Okay, we'll start in just a minute. I'm just going to just email someone to see if they're on. Oh, Cumberland can hear. Okay. Thank you, Cumberland. All right. Okay, we'll go ahead here. Okay. So today's program is approved for 2 public health credits and 2 nursing contact hours. I will go over how those credits will work at the end, but if you are watching the webinar as part of a group, you will need a group sign-in sheet, so if you want to start getting that together. For questions, again, you can enter any kind of a question into the chat box at any time during today, and we'll try to answer questions after each presentation and then also at the end. If we have more questions than we can answer, I will send out the responses to those questions after the webinar. Today's webinar will be recorded, and I'll show you where you can access that. Although, please be aware there are no continuing education credits for watching the recording. And the slides are currently posted on NJLMN under the Practice Exchange. You can see the little image there. I've put an arrow to where the Practice Exchange is located, and you'll see a button for Winter 2016 webinar, and the slides are there for you. In terms of the recording, we have a page now where we're posting all of our training resources for CDS. And you can get there a couple different ways. If you go to the main health department webpage and click on the orange public health box, once that opens up, you can click on communicable disease, and that will bring you to our main page. And you can see the button in the lower right, which says CDS Training Resources. That's where the webinars are located, as well as some other training resources. This is what that page will look like. And the link to get to that page directly is at the bottom of the slide. Just a few quick things before we start with our presentations. We do have several new staff that you may receive emails from or speak with on the phone or see at meetings, so we did want to mention some of those. Deepam Thomas is our new Foodborne Disease Surveillance Coordinator. She took over for Michelle Malavey, who left in June. She's been serving in an interim position, and she is officially in that position now. Patty Barrett is our Antimicrobial Resistance Coordinator, and that is a position formerly occupied by Rebecca Greeley. So we're excited to have someone fill that position, and she's been with the department since the summer working on Ebola infection control grant activities. Bridget Farrell, who some of my IP colleagues may know, has been hired part-time, and she's also working on the Ebola infection control grant, doing an infection control assessment that Jason Mayer will be talking about later today. And we have a new CDRSS coordinator. Her name is Della Surti. And most of you know we're going through a redesign with CDRSS, and she'll be sort of ushering that in and working with a lot of you on different training as that rolls out next year. So just wanted you to have those names. DOH, you probably saw the links message, is migrating to Office 365 and Outlook. We've been using a very antiquated Lotus Notes, and today is actually our migration day. So all of our emails have changed. You can see the new email format on the bottom. So you may just want to start updating your address contact books. So our new format is firstname.lastname@doh.nj.gov. Now, our old emails will bounce to the new address, we're told, for about a year, so it's not urgent, but at some point, those addresses should be updated. And today's agenda, the only change from what was sent out in the webinar announcement is in Lisa's presentation at 2:10. Talking about local roles and responsibilities. We've also asked her to speak very briefly on the H3N2 variant case of influenza in New Jersey, so she'll add that onto her talk. And otherwise, the agenda stays as it was. Okay. These are the required disclosure slides for nurses. Participants must attend the entire session, participate in all learning activities. Verification of participation will be noted by the webinar attendance reports or the group sign-in sheet that I mentioned, and completion of an online evaluation. You can't miss a lot of the session, and you are required to complete the online program evaluation and include your name and email address, and that's how we'll send you your nursing contact hour certificates. No commercial support has influenced the planning of the educational objectives and content of this event. No influential relationships have been disclosed by planners or presenters, and there's no endorsement of any product by NJSNA or associated with this session. Okay, and with that, I am going to turn it over to Ellen Rudowski. She's our Hepatitis C coordinator. I'm sure you all know her. And she is going to be talking to us about the new case definition for hepatitis C.
Thank you, Kim. So,
let's get this up here for you.
Okay, I'm on. Okay, I'm on. So as of January 1st, there is an updated hepatitis C case definition. I want to give a shout out to the nurses in Morris and Sussex, Passaic County, who piloted the case definition, I guess 2 weeks ago, when I was there in September and mentioned that the case definition was changed. They booked the presentation for January 4th. The buttons are working?
Sometimes there's a little bit of a lag. Wait, click it.
There it is. Okay, so what we're going to be covering today is the population-based focus that we have for hepatitis C surveillance. I'm going to review the case definition for acute and chronic. We're going to talk about steps to undertake in regards to an investigation. We all are very frustrated with negative Hep C serology studies going into CDRSS. And I'm also going to talk about some case management tips to help you identify those lab studies. So as far as the Hep C population focus, there's a change this year. We're focusing on individuals 30 years and younger. The reason for that is perinatal transmission. We know that there's an increase in IV drug users amongst 18 to 24-year-olds. And the current terminology is people who inject drugs, PWID. And we also want to rule out healthcare-associated infections. So you may recall from the statistics that I gave you in the webinar last January, we had 114 acute cases of hepatitis C. 71% of those cases involved people who inject drugs. And looking at this age group of 30 years old, 17 to 30-year-olds made up 53% of our acute cases. Now, the other end of the spectrum has been increased to individuals 70 years and older. We want to rule out healthcare-associated infections. We know that the CDC has instrumented Hep C testing on the baby boomers, so individuals born between 1945 and 1965. So if we do investigations or set our priority for individuals 70 and older, we won't be investigating cases for the individuals that have just had the baby boomer testing. cases with a referral medical facility listed, so it might be somebody that was inpatient. For corrections, there might be the terminology infirmary, as well as maybe an ER associate. Again, this is information that you've seen before. Ordering providers that are associated with a high-risk venue, and I included a couple of here: oncology, pain centers, dental care, podiatry, dialysis. So these are healthcare settings in which there is a high evidence of blood transmission. Individuals sharing a common address. We just had 2 acute cases in Cape May at the same address. Residential living centers, long-term care, assisted living, and it could very well be just calling the facility and asking whether or not they were admitted with a diagnosis of Hep C and just not previously reported to us, to DOH in the past. So the 2016 case definition starts with lab criteria. So we're familiar with the Hep C antibody screening with a 95% predictive positive signal to cutoff ratio. So that's the greater than 11 for LabCorp, greater than 8 for Mayo Clinic. The webinar last January, I gave you a printout of those signal to cutoffs. The next category you're also familiar with, it's the nucleic acid testing. So that's the Hep C RNA positive qualitative studies. So it's there or it's not, positive or negative, quantitative. They're giving you a value of what the viral load is, or a genotype. You'll see over to the far right a third classification, which is a positive hepatitis C viral antigen. It's circled in red. There's an asterisk. So this will be part of the case definition when and if the HCV antigen test is approved by the FDA. Okay. We do have hospitals that do this antigen testing. It is approved by the FDA for screening only at this time and not confirmatory. So that's why there's an asterisk. Another change is you see that the Reba is gone because that has not been manufactured since March 19, 2012. So the CDC has pulled the Reba off and added this antigen, which isn't available at this time. In regards to the case definition, you'll see for acute clinical criteria, the symptoms remain the same, a discrete onset of clinical symptoms that are consistent with acute viral hepatitis, and they have to have jaundice or the ALT level has been decreased to 200. So if you look over on the right, the clinical presentation is the same as the 2012 case definition, but the ALT level was decreased from 400 to 200. With chronic, chronic stays the same. The clinical presentation stays the same as 2012, and I just want to take the opportunity to point out that most chronic Hep C infected individuals are asymptomatic, but it is the leading cause of liver cancer. And infants. So the CDC does not include the infants in the 2016 case definition. New Jersey is not letting them slide by. So the New Jersey case definition includes as chronic illness persons less than 18 months of age, just like we had in the 2012 case definition. And that would be if a child 18 months of age or younger had a positive nucleic acid test, so that's a positive RNA virus, the qualitative, the quantitative, the genotype, and then once again, when that antigen is FDA approved, that would be indicative of Hep C virus in the baby. Notice over to the right in bolded statement is it does not include antibodies. So we know that maternal antibodies are passed on from the mother to the infant, and they don't wane until 18 months of age. So just like 2012, this slide deals with the children 18 months and younger. This is the two categories side by side, or one on top of the other, to be correct. And you can see that it's acute confirmed and chronic confirmed. Those are the only classifications that are being used by New Jersey. The CDC does have probable case definitions, but that requires all antibodies being reported to the state. And we're not doing that this year. Possibly next year that can happen, but right now that isn't happening. So for the acute confirmed case, it meets the clinical criteria, has a positive Hep C virus detection test. That's one way to be acute. Or if you have a negative Hep C antibody, negative Hep C antigen, or negative nucleic acid test results followed by a positive within 12 months. That's a little bit of a change. Remember, in 2012 and prior to that, it's always been 6 months. So the CDC did extend that period. For chronic confirmed, it's the same. A case that meets the clinical criteria has no report of any clinical symptoms, does not have a seroconversion within 12 months, or no report of a test that converted in 12 months, and has a confirmatory Hep C result, like the signal to cutoff, which is 95% predictive, true positive, a confirmatory Hep C nucleic acid test, or again, that Hep C antigen test when and if it is FDA approved. So as far as the case investigation, with acute cases, the case interview, we want to identify past exposure risk factors, and that's throughout the 6 months prior to symptom onset. Provide hepatitis education, which includes the methods of transmission and liver preservation measures. Hepatitis A and hepatitis B vaccination, single or double dose, double antigen are recommended, again, to protect the liver from further insults. The over-the-counter and liver toxic medications and herbs, high-potent vitamins. This is something that the case should speak to their doctor about. And alcohol abstinence. So you're going to do a little assessment whether or not they consume alcohol and deliver the message. Some physicians say 1 drink daily is fine. Please note that research for the last 2 years has said no alcohol at all. And the exposure factors currently listed by CDC, most of these we know about. The blood transfusion, organ or tissue transplant prior to 1992, the clotting factors prior to 87, hemodialysis, the non-prescription drugs by injection or by snorting. They just changed that language a little bit, so that'll be reflected in our risk factors. Direct contact with blood-to-blood exposure or blood to mucous membranes with, so of course it's somebody else's blood. Close contact with someone diagnosed with hepatitis, and they added live with, share personal items with a Hep C infected household contact. So whether it's razors, tweezers, something else they specifically identified. We know about the tattoos and the body piercing, if they receive treatment for an STI, if they've had surgery, if they received injection medications, these are already in CBRSS, or had a medical procedure. And then born to a Hep C positive mother, that's in CBRSS as perinatal exposure. So with some of the serology studies I wanted to talk about and give you some examples of closing a case. So again, we discussed this at the webinar last January. So if you were to have a confirmatory signal to cut off with the 95% predictive confirmatory index and a negative Hep C RNA, that could indicate no current infection or that the person is not replicating at the time of the lab draw. So often the doctor will order that test again in 6 months to a year. The viral replication may be below the lowest level of the test assay range, and I do have some screenshots from CDRSS to show you that, or that there was a past Hep C exposure. So for those cases, it's going to be closed as chronic confirmed LHD closed. Negative serology studies, like I said, we all find this very frustrating. Part of what happens is the regular Hep C antibody screening tests are not reportable in the state of New Jersey, and so you are seeing a negative RNA test result without the positive antibody prior to that. However, these positive antibodies are reported to many other states across the nation. And the CDC has requested that negative results go into our electronic system. Eventually, they're going to be looking for viral clearance. So for these cases that just come in with a negative serology study, you can just close them out. You don't need a subtype. You can leave that as pending. Not a case, does not meet case definition, LHD closed. Insufficient specimen for genotyping. So this is a case that's created only with a Hep C genotype test result. And in the value, it says specimen has insufficient HCV RNA virus to obtain the genotyping. These cases, you can leave them as pending. They're not a case. They do not meet case definition. They're LHD closed. And here's a screenshot of what that looks like. Now, if you click on the Hep C virus genotype, if you click on those words, what you're going to see is the interpretive message. So over on the right-hand side, where the value is, that's where that message is about insufficient specimen. But if you go down to the interpretive message, it's telling you that the lab, in this case, needs at least 1,000 international units per milliliter of Hep C virus in order to come up with a genotype. This is LabCorp. You can see here they require 1,000. ARIP requires 1,200. Mayo Clinic is also 1,000. So this is not a negative result, but it's not a positive result. So that's why we're closing the case. It's not a confirmatory result. So that's why we're closing the case as not a case, does not meet case definition. The other thing that we discussed in January 2015 webinar was the PCRs that are less than 15. So what's happening is the lab tests, laboratories are doing a qualitative and a quantitative study. And so sometimes you see the -15, and then it might say ND. The ND stands for not detected. Those cases, and if you were to, again, click on the words of that test and look at the interpretive message, it will say HCV RNA not detected. So these cases are being closed out as not a case, does not meet case definition, LHD closed. Sometimes you see that the value is just less than 15 international units per milliliter. Again, if you click on the test message, it will say HCV RNA detected. LabCorps usually come up like this. And so these cases are closed out as confirmed. case status reason, we don't need a reason for a confirmed case. And then the report status is LHD closed. New York State Department of Health electronic lab reporting cases. So we don't get good data from New York with their electronic. This first bullet here shows you this is how the case is created. So up on the top left, you know, it will say electronic NJDOH. They do send us some positive HCV RNA qualitative, quantitative, and genotype results, but most of them are low positive signal to cutoff ratios. So this could be a 0.4, a 0.3, so something that is not at that 95% predictive positive ratio level. Again, Hep C antibody screens are anything greater than 0.09 are reportable to the New York, New York Department of Health, and they're not reportable to New Jersey. So in the current CDRSS system, there's no way to prevent these cases from being created. This is a surveillance report that I run every 2 weeks. I try to close them out before you can get to them, but that doesn't always happen because I have so many responsibilities. But with great news is with the updated version of CDRSS that is going to roll out January 2017, we'll have the opportunity to e-close cases based on a lab test result. So just hang in there for one more year. Great things will happen with the new iteration of CDRSS. And here's a little problem that may occur. This case was created on July 3rd. It came in with a Hep C RNA result with a viral load of 351. And because of the sheer volume of Hep C cases, we don't get to them right away. This case was closed out, though, in August as not a case, LHD closed, reopened in November because it hadn't been DHSS approved yet, and we see here the negative genotype, not negative, a non-confirmatory genotype test result. So a little quiz. How are we going to close that case? On 7/2, when the case was created, we had a confirmatory test result. We then had the insufficient test result following November 5. The case closeout is going to be subtype chronic, confirmed. The case status, again, is not needed for a confirmed case, or the reason for the case status, and the report status is LHD closed. And the rationale for this is because the case was created in July with a confirmatory result. The local health department did correctly close this case out as chronic confirmed LHD closed, but then this genotype came in and reopened it. Okay, but that was just a little quiz. So some tips I wanted to share with you, a little shortcuts to seeing these positive labs. And I sent out a couple hundred emails the last couple weekends, and everybody's waiting for this. So when you do a case ID search, you can see here that the case ID is blocked out. On the left-hand side, you have the person's name, last name, and then followed by the first name. And then there's Hep C chronic is the disease, or I would just say Hep C. If you click on this flask, this pop-up screen comes up, and you can see here that it says Hep C RNA quantitative not detected. Again, this is what it looks like when the case is created by electronic New York Department of Health.
and the case was updated by me. But if you just click on this little blue icon, you can review the labs before you even go into the case. So at that point, you just click on the Hep C, you go to the case classification, you make it not a case, does not meet case definition, LHD closed. Less clicks translate into less time it takes to do this. I know you're all aware that before I enter any Hep C case, I click on the person's last name because there are thousands of duplicates that come through every year. So in this situation, you're in your pending screen. I clicked on the person's last name. No duplicate people came up. I clicked on the last name again, and this is the field that comes up. And right here is the person's address I blocked out. Behind the screen is the person's last name, as well as over here is their telephone number. Here's the last name. Here's their date of birth, all blocked out. And if you just click on this lab test history, this pop-up screen comes on, and it tells you that here's the signal to cutoff, and the result is 0.05. So we know that's not greater than 11 or greater than 8. So right off the bat, when we then click on the case ID, we can go in, go right over to case classification, make it not a case, does not meet case definition, and LHD close it. Here's some Hep C resources. I love hepcadvocate.org. There's also a hepbadvocate.org. They have the latest information on hepatitis B or hepatitis C, respectively, and there's blogs, support groups, medication updates, clinical studies, locations. So this is the best comprehensive site. And that's it. And notice the new email address. Any questions?
Oh, thank you, Ellen. As a reminder, if you have any questions, you can type them in at any time during the question box, and we'll just wait a minute and see if we have any for Ellen. Well, Ellen, you must have done an excellent job. We have no questions. If you do have questions, we can take them a little bit later as well. But for now, we're going to continue moving on, and I'm going to turn it over to Lisa McHugh. She is, as I mentioned, going to talk very briefly about the H3N2 variant case in New Jersey, and then move on to some case scenarios looking at local roles and responsibilities. But before I turn it over to Lisa, we did get one question, Ellen. The question is, are hospitals still required to report hepatitis C antibodies?
The signal to cutoff that are at 95% predictive value are reportable.
But antibodies without the signal to cutoff ratio or not.
Right. So it's important to talk to your laboratories and see exactly what instrument they're using and what they're reporting as positive. Often it is a signal to cutoff, and the hospital will only report out, just let's use the example of a confirmatory greater than 11. If it's greater than 11, they're reporting out that result as positive. Many hospitals don't report out the low positives. In that case, it would get reported and it would be greater than 11.
Okay, thank you, Ellen. Lisa, I'll go ahead and turn this over to you.
Perfect. Thanks, Kim. Thanks, everybody, for joining us. I know you're all very busy, so we hope you find this informative. So we did send out a message last week about the first case of H3N2v that was detected in New Jersey, so we did want to just give a brief update about that. So as many of you know, we've talked about this in some of our previous forums and gatherings. H3N2v was first identified in pigs in 2010 and identified first in humans in July of 2011. Since that time, in August of 2011, there's been a total of 346 cases, with the majority of those cases occurring in 2012, with 309. And of those, the cases have been relatively mild, mostly in children and young adults. And of that 309, only about 20 hospitalizations and only 1 death. There's been very limited human-to-human transmission, and almost all of the cases have been associated with prolonged exposure to pigs, primarily associated with different types of agricultural fares and settings. The case that was detected here in New Jersey was a 9-year-old male with onset of symptoms on 12/26/2015, had fever, sore throat, headache, muscle aches, and nasal discharge, and was evaluated that same day by a healthcare provider where specimens were collected for testing. The individual was positive on a rapid influenza diagnostic test for influenza A and was provided antiviral treatment course for 5 days. The child had no underlying medical conditions, but the specimen was sent to the state public health labs as part of routine surveillance, and the child fully recovered. We were notified on the 31st by our state public health lab, who conducts routine testing for both seasonal and novel influenza on every single specimen that we test. Once that test result came through, that's an immediate notification for us to contact our CDC colleagues, and we did so. And preliminary information from the family indicated that there was no contact with agriculture or swine. At this point, our CDC colleagues, because we were entering a holiday weekend, asked us to delay the shipment down to them for confirmation because of the holiday. We can tend to get specimens sitting at CDC and then have to recollect specimens, and that would not have been possible in this case. So we did regroup after the holiday. We conducted an additional interview with the family, and in fact, they reported having some contact with swine on 12/24. We also have protocols in place that identify any novel flus with connection to agriculture must be reported to the Department of Agriculture, and that process did begin on that day, and as well as message development. We finally received confirmation from CDC of the test results of H3N2v on the 5th, at which point a joint response between state public health, local public health, and our partners in agriculture was being developed. On the 6th, we conducted a joint site visit of the area where the animal was located, and CDC, in fact, then confirmed by genetic testing that the virus was of swine origin and was similar to that was found circulating in swine. On the 7th, we had a links message that we sent out, both to remind providers about inquiring about animal exposures among individuals with influenza-like illness, as well as the reporting and testing protocols for novel influenza H3N2v. As far as what the response was, we created a frequently asked question page that was provided to workers on the swine premise with any questions. A risk survey was also conducted for the workers, at which point we found no current or past illnesses that were noted. However, all workers were asked to abide by a 10-day period of self-observation and report directly to public health with any symptoms. There was educational signage also provided for the premise. We did internal and external partnering both on our messaging and the response. Our NJDOH colleagues, the Department of Ag, reported that there were no additional animal illnesses noted. We did send a links message, and the actual case was also announced in the CDC FluView report. So just some lessons learned. Routine surveillance did in fact work to detect novel influenza, but there is also a need for us to provide more frequent reminders about the novel influenza risk, particularly when we're in the middle of a flu season. While the flu season has been mild, sometimes providers just think this is traditional seasonal flu and do not ask about potential animal exposures. And we could have identified this novel case, may not have identified this novel case had this not been a participating sentinel site. Joint response about multiple agencies was very effective. We have been working diligently on protocols with that agency, particularly our partners in agriculture, and it worked very, very well. And in this particular case, it was necessary to re-interview the case and ask some more clarifying and specific questions in order to get at the actual exposure. And you know, the lesson learned that we all have is that all significant events always happen on a Friday at 4 o'clock or on the day before a long holiday weekend. And isn't that the truth? So I'm going to move into kind of the opposite of this, and we'll have time for questions after the presentation, and hopefully at the end if there are anything lingering. And of course, you'll all email us at our new email address at nj.doh No, DOH.NJ.gov. It's new. It's new today for us. We're still learning. So I'm going to start talking a little bit about communicable disease investigation case studies. And just as an aside to note, you know, we get a lot of questions from different health departments about how other health departments do things or what our recommendations are. And so we tried to put something together to kind of just talk about what some of those scenarios are and present some of those scenarios for clarification. I do want to say that I am not a legal expert. I've put together some common scenarios that we often get a lot of questions about roles and authorities of local agencies, and I've tried to provide citations to the statutes and regulations where possible. I'm going to specifically focus on communicable disease, but clearly these statutes and regulations apply to much more broader areas. And many regulations can be acquired through the Department of Health webpage through LexisNexis, which we all know is sometimes a little bit of a bear to get through. But our partners at the New Jersey Learning Management Network also have numerous regulations posted that are redacted, and they can be found under the Practice Exchange tab. And New Jersey statutes are actually can be acquired through the legislative website or in published book formats. And I've provided those links at the end of the presentation should you want to have some nighttime reading material. So I'd like to just first start off about, you know, what governs what we do here in public health with a brief description. So we have the New Jersey Statutory Authority, which are written laws that are passed by a legislative body, versus New Jersey Administrative Code, which are rules that are adopted by particular state departments. And in this case, the New Jersey Department of Health, which implements specific portions of those laws that are passed. We have the New Jersey Statutory Authority Title 26, which is found under the Health and Vital Statistics. And this provides the establishment of state and local health departments and governing bodies. It gives broad powers to take necessary action to ensure safety of public health. And this is a law that both regulations that I'm about to talk about are housed under. New Jersey Administrative Code, Title 8, Chapter 52, is the public health practice standards of performance for local boards of health in New Jersey. This defines both local health department services and capacity. It ensures response to public health issues, so the 24/7, 365 availability, insurance of trained staff, identification of health threats, investigation of the cause of a particular outbreak, and implementation of control measures to prevent the spread of that disease. Title 8, Chapter 57 also links into Title 8, Chapter 52, and this defines reportable conditions, reporter responsibilities and timeframes. It defines health officer responsibilities, investigation of reports based on where the patient resides, isolation and quarantine, medical examination and specimen submission, as well as the exclusion of certain food handlers. So I'd like to first talk a little bit about jurisdiction. We get this question a lot, and the following is very generalizable across multiple reporting conditions, and it really doesn't matter what the reporting entity is, whether it's a healthcare provider, laboratory, or institution. And of course, then there's also based on reportable conditions, whether they're immediately or non-immediately reportable. But the following has really been excerpted directly from our regulations. Healthcare providers, laboratories, institutions shall report to the health officer of the jurisdiction where the ill or infected person lives. If that is unknown, then it gets reported to the jurisdiction where the actual diagnosis is made. The exception to this rule is if it's a state institution in which that report can come directly to NJDOH or specific reportable conditions as defined within the regulation. So we have a very unique setup in New Jersey, and we have several different types of agencies with different levels of responsibilities. And again, I'm talking specifically in terms of communicable disease investigations, as this sometimes changes with various different types of activities throughout the department. But in general, we have links agencies, which can also be county health departments that have jurisdiction over the entire county population. They are local health departments which cover all jurisdictions that are in that county, and no local health departments exist outside of that links agency. The second type is we have links agencies that are also county entities, but they themselves have no health jurisdiction over the population of the county. However, there are multiple local health departments that exist within that county and are covering one or several jurisdictions and have health jurisdiction over that designated population. finally, we have links agencies that are county entities and have some health jurisdiction over the county population. For example, 1 or 2 or 10 municipalities, with other local health departments covering the remaining jurisdictions, municipalities in that particular jurisdiction. The health jurisdictions that I speak about, it also impacts the communicable disease investigation and how where reports are reported and how they're conducted. And so this is just kind of a breakdown. And first, I will apologize because a lot of this stuff changes rapidly. And so if I place something in a different color, my apologies. But you can see that we have under category, the first category I described, there's 8 counties. In category 2, that's where 5 counties fall. And in category 3, where an additional 8 counties fall in that particular structure. So now I'm going to start to go into some of the scenarios to talk a little bit about some of the questions. And we're going to pepper throughout here some poll questions to kind of spice things up and keep things moving along here, and hopefully you're paying attention. So bear with us. We may have slight technical difficulties, at least getting into the first one, but hopefully it'll work out just fine. So a food worker who's responsible for preparing salad at a very busy restaurant is diagnosed with hepatitis A and was symptomatic while working. The local health department reports the case to the Department of Health, and the department provides the following guidance: identifying close contacts, including household contacts of the patients, identifying coworkers at the restaurant, and identifying anyone that may have been exposed at the restaurant, and provide them with either hepatitis A vaccine or IG, depending upon the age recommendations that are stated in the guidance. There's also an exclusion for any food handlers that are not in compliance with this recommendation. So let's suppose in this investigation that the restaurant, the case, and the majority of the contacts reside in a single local health department jurisdiction. Let's also presume that this local health department is not a links agency. And so the common question that we often hear is, as a links agency, why am I not notified of a communicable disease investigation? As we discussed previously, the responsibility rests with the health officer of the jurisdiction where the patient resides. And in this scenario, the increased involvement, there's an increased involvement as the restaurant and the contacts are also located in that same jurisdiction. So the communicable disease service will work directly with that particular health officer. Local health department health officers can certainly request assistance, share information, or involve the links agency in response. But this is done at the discretion of the local health department health officer and should be based on an agreement between those two agencies. It would not be possible for the communicable disease service to know what type of agreements between each local health department has with their links agency. And we're happy to work and involve whomever that local health department health officer wishes us to involve. So many folks say, well, why is that? Well, besides being part of regulation that requires reporting of that reporting directly to the health officer, there is some concern about HIPAA. So many folks think that because we are exempt from HIPAA, that there's no responsibility to this law, and that simply isn't true. We have the ability to collect personal identifying information associated with public health investigations. But once we obtain that information, we also have a responsibility to keep that information confidential, and with breaches only being allowed if it's absolutely necessary for protecting the public's health. The bottom line is we cannot be sued for obtaining personal identifying information as part of a public health investigation, but we can be sued if it's determined that the information we shared was more than with those that needed to know. And if there's permission in place to share that particular information, we are assuming that those agreements are in place and that it's needed for a public health response. So we're going to move into the poll questions. Although I can't see them. They're coming over there. Okay. Sorry.
So I'll read the poll question. So the question is, what is the responsibility of the local health department in regards to PEP based on this scenario? So if you can please vote on your preferred choice, either informing all contacts and telling them to consult their private physician, purchase vaccine and IG and offer it to all contacts, purchase vaccine and IG but only offer it to those with no insurance or who don't have a physician, or unsure. So we'll give that a minute or so. Okay. All right. Okay, so since Lisa doesn't have her right glasses on, so the responses are about split, with about 37% saying that they would inform all contacts and tell them to consult their physician, and another 37% saying that they would go ahead and purchase the vaccine in IG and offer to all contacts.
So great. So this is kind of a trick question because not really any of these answers are necessarily wrong. We would say that the best answer is probably B. This really helps to ensure that public health is assured that all contacts receive PEP in the appropriate time frame at the correct doses and in a safe manner. You know, answer A is not necessarily wrong, but sometimes people go to their private providers and we don't know what's happening or what kind of advice or recommendations they've been given, and it makes our lives a little more difficult to follow up. So trick question, really none of them were wrong.
Okay, we're going to move on to a second question, but real quick, I did have a question on what is PEP. PEP stands for post-exposure prophylaxis. So in this particular scenario, you'd receive either IG or vaccine, depending on your age. All right, so we will. All right, here's our second question. Okay, again, based on this scenario where post-exposure prophylaxis is needed for a large group of people, what would your health department do? Would you provide it for free only to residents of your town? Would you provide it at a cost only to residents of your town? Would you provide it to anyone, regardless of residence, for free? Or would you provide it to everyone, regardless of residence, for a cost, or if you're unsure about that? We'll give it a minute for voting. Okay. All right, so 46% said that they would provide it to anyone regardless of residence for free, followed by 23% who would provide it for free, but only to residents of their town.
So again, a little bit of a trick question. They get easier from here, but the best answer is probably C. Again, none of them are necessarily wrong answers, but again, we're in public health, and it's really our job to protect the public health. And if this town event occurred in your town, you know, it's clearly not the health department's fault. It's usually not the restaurant's fault that this happened. And certainly we recognize that there's also budgetary constraints by a lot of local health departments. But I think you should also know that there are laws in the books that give local boards of health the ability to request monies through certain purposes. So for example, in the statutory authority 26(3)-44, there are different things that allows your local boards of health to lobby to get additional funds, specifically for contagious or infectious diseases, in order to get appropriated so you can implement the appropriate control measures. All right, so we're back on the slide. We're going to go through a couple more scenarios. So you receive an anonymous call from a parent regarding an outbreak of rash-like illness in a school. You contact the school and they confirm the existence of an outbreak. The local health department provides guidance. You'd ask for a line list, diagnosis of illness, surveillance for additional cases, and you certainly recommend control measures, hopefully based on the New Jersey Department of Health School and Child Care Guidance documents. The local health department then calls the school on the following day to collect the requested information that they've asked for and to get a status update of any new cases that may have occurred and what the status is of implementation of control measures. The school indicates that they're not following the recommendation as it's really not that bad. It's only a few cases of rash, and it's probably associated with the kids who went on that class trip last week. So based on that scenario, the local health department should consider.
Okay, so another poll. So the options here in this scenario, the local health department might consider going to the school and conducting an assessment, continuing work by phone with the school since the health department is not allowed to inspect schools, sending an inspector to assess the kitchen and the hand washing areas, or waiting a few days, and when the outbreak worsens, the school will decide to cooperate. We'll give that just 1 minute. Okay. And 90% responded that they would go to the school and conduct an assessment. Only 1% said they'd wait a few days and wait until it got worse.
So absolutely, the correct answer in this particular scenario is A. When a facility or school is not cooperating, it is appropriate to send staff and get the information that's critical. Certainly answer C is not bad, but just inspecting the kitchen and hand washing areas is not really something we'd be terribly concerned about with a rash-like illness. Although if this had been a gastrointestinal illness, that might be something we might want to consider. Probably not a good idea to do answer D, and that was pretty evident. But once we get to answer A, the question that we often get asked is, do I have the power to enter a school to conduct an investigation? And the answer is yes. And so I've provided one of the links here, and this is kind of a lengthy slide, but it does talk about New Jersey Administrative Statutory Authority 26-1A-18. And this particular statute that I have listed here specifically talks about the Commissioner of Health, but that they can enter upon, examine, and survey any of the following. And you can see here that schools are part of this if the reason is believed that there's some type of violation of any health law. So the next thing you're going to say, but this applies to the Commissioner of Health. Well, there's subsequent statutory authority 1A-20, which essentially says that if the Commissioner has power to do it, so does the local health officer. And so, in fact, we have local health officers have the ability to enter any of these premises that they may need to in order if there's public health issues that are occurring there. So we're going to continue to move on. Similarly, based on this same scenario, can a child with an undiagnosed rash be excluded from school? So no, only a child with a diagnosed illness can be excluded. Yes, a child with rash can be excluded until diagnosed, or we're not sure. Wow, this is a great audience. So again, that is the answer. So answer B. So yes, a child with a rash can be excluded any child can be excluded until the cause is determined. And this is because local health departments have very broad powers, and that's located in several places, both in regulation and in statutes. You do not need to have a diagnosed condition in order to exclude. You just need the notion that something could be infectious and may be spreading. Should it be diagnosed and determined to be not contagious or can be appropriately maintained while they're in school? So, for example, if it's a particular rash that keeping the rash covered allows the child to stay in school and not be contagious, then the child can certainly return. And I have some of the citations listed at the bottom of the slide, which specifically pertain to this exclusionary practice. Okay, so based on the previously presented scenario, the school is receiving a lot of pressure from parents to close the school until the outbreak is resolved, and the local health department advises which of the following: close the school immediately, use investigational findings to determine if closure is needed, close the school for a day for cleaning and sanitizing, insist that they stay open. How will you investigate if they're closed, or you're not sure? Great. So many folks chose answer B, which was use the information from the investigation to determine if closure is warranted or needed. Secondly, for closure, some folks said close it while it can be cleaned and sanitized. And so while it's true that New Jersey Statutory Authority 26-4-5 gives health officers the ability to close a school, this may not always be necessary. And we do have specific guidance and criteria recommended in the school and child care guidance that's provided by NJDOH. Sometimes schools will make this decision about closures all on their own, and they won't contact public health, nor will they look to us for some science-based guidance. But again, best answer here is the second answer. We encourage schools to work with you to determine whether closure is necessary and if it will be effective. Also, I would caution that you be concerned about answer number, the third answer. As often, once schools are closed to be sanitized and cleaned, the next question that often comes is, Can public health tell me when students, staff, and parents that the school is now quote-unquote safe? And you lose credibility when you say yes and then additional cases occur. So you need to be very cognizant about saying, oh, well, it's clean and sanitized and the environment is safe. We want to make a safe environment clearly for these schools, but we have to be careful that just closing it down for a day and cleaning and sanitizing does not necessarily end any particular outbreak. Okay, so we're back to the slide.
Okay, not yet. Hold on. Uh-oh.
Go back.
Oh, just a minute.
I'm on the right slide.
You are?
Yeah.
Let's go.
Okay. So we're going to move on to some questions. We receive a lot of reports about the involvement of licensing. And so in this particular scenario, you receive a report of an influenza outbreak in a long-term care facility. The facility also reports that they have informed licensing of this outbreak. The local health department provides basic guidance to the long-term care facility, again, hopefully using the long-term care respiratory guidance that's provided by the Department of Health, and then reports the outbreak to the state health department. You follow up over the next few days and find out that the facility is not complying with your recommended action. Oh, yes. So based on this scenario, what should the local health department do? Nothing. It was reported to licensing, and they should ensure that the facility is implementing precautions. The second one, call licensing and report the facility. Third, close the facility or work with the facility to implement the recommendations, or we're unsure. Terrific. So as we'll talk about on the next slide, it is really not the responsibility of licensing to conduct an investigation into the specific outbreak. Additional reporting to licensing without cause will not really necessarily help in this particular scenario. We also need to be cautious about the closure of the facility. You can close the facility to new admissions, and in some circumstances that is absolutely recommended. But where would the people of this facility go if it were closed? If they are infectious but asymptomatic, do we want to make the problem worse by sending them to other facilities and creating additional outbreaks? Having a licensed facility does not limit the power of a health officer. The role of licensing is to enforce their regulations. And while they're certainly concerned about the health of the population, it's not their job to conduct an outbreak investigation. However, when licensing is involved, it can complicate an investigation. Facilities tend to confuse public health with licensing. We want to help the facility correct the problems before licensing ever needs to get involved. The fact is even the best run facilities will have outbreaks, particularly during respiratory and GI seasons. If they're working with us and complying with all of our regulations, there's often not a need to get licensing involved. If, however, there are continued refusals to follow public health recommendations, and this is causing the outbreak to get worse, there may be a need to report to licensing and ask for their involvement. But be prepared to provide written documentations, particularly if there's faults with any particular facility. So we're going to move on to another scenario. There's a Legionella outbreak in a long-term care facility. There was an initial epidemiologic investigation and environmental assessment conducted at this facility, and that led to a water system remediation. After the remediation, there may also be a need to conduct follow-up surveillance for new cases, sometimes up to a year, regularly following up with the facility regarding scheduled water testing and results. Again, often this can be as long as a year. Report findings of all of the above that you've collected, and in some circumstances, conducting additional investigations may be warranted. So in the above scenario, what is the local health department's responsibility? Just give it a second to get the poll question up. Work with the facility and update DOH when over with the final report. Work with the facility. Provide updates to DOH as requested. Nothing, the case investigation and remediation are over or unsure. All right, so a lot of folks said work with the facility, update DOH when the report is final, but the majority actually said continue to work with the facility and report as a frequency determined by NJDOH. So there are additional investigations that are often associated with disease investigations, and they're more than just reporting the results of that investigation or including them in an outbreak summary report. Some investigations can go on and continue for upwards of a year, as we've seen with a lot of Legionella investigations. And there is still a responsibility of the local health department to continue the investigation and follow up on these particular situations. So for example, 857.110G talks about the health officer submitting a summary report within 30 days of the completion of an outbreak. But we also have heard many folks tell us that they're not responsible beyond that initial report. But that is not necessarily the case. In NJSA, Statutory Authority 264-24, the health officer shall at least once each week and daily when required by the state health department transmit full information concerning the measures employed by the local board to prevent the spread of diseases. So in fact, per regulation, there is a need to conduct those investigative follow-up questions. So again, I mentioned at the beginning of this presentation that we would provide some additional resources on where you can get some of these statutes, and that's on this page. And finally, if there's any questions, I will do my best to answer them, and as many other presenters, please note the change in email.
I think we have a technical problem where we keep seeing this slide about the kid with the rash, and we're seeing that as well. Let me see if we can just fix that real quick. Lisa, do you want to look at some of the questions here? Let's see. There was a question back on the H3N2. Did the swine display signs and symptoms of illness? Yes, actually the child was seen by a healthcare provider because they had influenza-like illness, and that healthcare provider appropriately tested and treated that individual for their illnesses. Okay. Looking at hepatitis A post-exposure prophylaxis, there was a question, does that need to be offered within a certain number of days?
2 weeks.
So the answer is yes. It's 2 weeks from the last exposure, and the determination of whether vaccine or IG is offered is based on the age of the individual, and there are guidance documents that are available on NJDOH website specific to Hep A prophylaxis. Okay. Could someone just respond in? Are you currently seeing a slide with Patricia Mason's information on there? Someone could just, yes, okay, good. I think we got it back then. Great. Let me see if we have another question. A couple questions about funding for PEP, I guess for hepatitis A as well. Is there funding? Why isn't there funding from the state for PEP? And if local health departments apply for funding for PEP to cover residents for free, would it also cover the creatinine clearance, liver function tests, and other lab tests that are required for prescription testing that are necessary before prescribing PEP? So there's currently no available funding for, at least from the Communicable Disease Service, that's provided for to local health departments for the provision of providing post-exposure prophylaxis or any of the other things that are mentioned in that particular question. But as I've had conversations with local health officers, there are some ways to build in contingency funding into local health department budgets that should some of these events occur, that there's a contingency in place that appropriate public health measures are taken. often if there's an exposure that occurs, there's no testing that's needed. If an exposure occurs, the recommendation is simply to provide vaccine or IG if necessary. So those particular cases where there was testing mentioned, that's not something that's part of the required recommendation for providing PEP.
Okay, one additional question. Could you give a brief update on the influenza season in New Jersey in terms of our level? Is it getting worse or better? What strains are circulating?
Well, those are a little bit of difficult questions for us because we're not seeing a whole lot of circulation. So at this time, it's pretty difficult for us to tell you what the predominating strain is. CDC, based on national, has been seeing both a smattering of influenza A H3 as well as 2009 H1N1. We've had very limited circulation of influenza to date. CDC is quick to point out that we have had historically early influenza seasons within the last 3 to 5 years, and that a typical influenza season usually does not peak until the middle of February. And so it is actually possible that we are just actually encountering a typical influenza season that we have not seen really since the pandemic. And so we are continuing to be vigilant on looking for influenza-like illness and for some specimens. Before I came down here, I can tell you that I just got a batch of results from the State Public Health Lab, and there were several positives within that report that will get included in next week's weekly flu report. So we're beginning to see some activity during this week, but we'll see if that continues to increase as we progress. I would suggest that if you're interested in following it, make sure you're looking at the weekly flu report, which typically goes out on Wednesday. Because of some of our migration issues this week, it may not go out until tomorrow morning.
Okay, thank you, Lisa. And again, Lisa will be able to answer any additional questions at the end. Currently, I'm going to turn it over to Patricia Mason. We've had several questions from different local health department partners about some changes that may be in the STD program and how that might affect local health departments specifically. So most of you know the STD program is not located within the Communicable Disease Service, but we did reach out to them, and I'm happy to say that Patricia is here and going to give a very brief overview of the STD program and hopefully answer some of your questions. So with that, I'll turn it over.
Hi, everyone. I hope everybody's not sleeping yet. How do you do this thing before?
That's the click.
Okay. Oh, wrong side.
Click on the left.
Yeah. Okay. Just wanted to give everybody an overview of what our department, the STD program, does. I wanted to let you know who we are and why we're there, because there's been some confusion. So I kind of wanted to clear that up for everyone. And I'm going to start by talking about our mission. Mission of the Sexually Transmitted Disease Program is to reduce the burden of reportable sexually transmitted diseases and related complications among residents and visitors of the state of New Jersey. To accomplish this mission, the STD program is coordinating in coordination with internal and external stakeholders, will notify and ensure medical evaluation for individuals and their partners who are diagnosed or exposed to an STD. Now, the STD program supports local health departments, STD programs, and other community health care providers in high morbidity areas. We focus on these areas because that's where health disparities are. And we help to design, implement, and in some cases evaluate program components such as patient medical care, laboratory services, and prevention and intervention activities. We also initiate and provide direction for targeted STD, which would be right now gonorrhea, chlamydia, and syphilis screening, in collaboration with the New Jersey Family Planning League, local health STD clinics, correctional facilities, juvenile detention centers, community health centers, and school-based clinics. I'm going to talk directly to local health departments because I think most of you out there are from the local health departments. The STD program collaborates with local health departments and clinics to assure compliance with best practice for STD services and provide technical assistance to local health departments whenever necessary. The STD program has the following systems in place to assist local health departments accomplish their STD prevention and intervention mission. The first one would be, we provide small health service grants, and I mean small health service grants to supplement local health department STD program activities. We are also part of the 340 340B medication program, and so we provide free medication to STD clinics. We also provide free gonorrhea and chlamydia test kits through the public health, environmental, and agricultural lab. We also collaborate with the New York State Training Center to provide partner services training. And for those of you who don't know what partner services, we changed this name a couple of times. Partner services training would be for the person that's responsible for actually locating positive patients and interviewing them and providing services for their sexual partners. And 5, the public health representative, which we call DIS staff, disease intervention specialists. We have different names for them throughout the country. They're placed strategically throughout the state to assist local health departments with coordination and implementation of community education, partner services, medical and laboratory services, surveillance and data management, training and professional development, and STD outbreak response. Technical assistance is also provided by the field staff in areas such as targeted STD screening and updates on resurgence of such things as resistant gonorrhea, which is around right now, and most recently, LGV has reared its ugly head. It's back. Somebody in New Jersey, Atlantic City, as a matter of fact, was spotted that had LGV. Didn't live here, but visited New Jersey. So, I just wanted to point out to everyone what the reportable STDs in New Jersey is, and that everyone who provides service, and if you have a patient that's positive, these things need to be reported and reported promptly to the health department or Department of Health, I should say. Chlamydia, which includes neonatal conjunctivitis, gonorrhea, any positives, syphilis, all stages, and congenital. Luckily for us in New Jersey, we have not had congenital syphilis in 2 years. And we're unique in that because congenital syphilis is going up across the country. Chancroid, which we have not seen in many years. The last time I saw this was like in the 1980s back in Florida. Granuloma inguinale and lymphogranuloma venereum, which is LGV. So those are the reportable STDs. Just to give you an idea of what's going on with the most common STDs currently, I just gave you, put some data that you could look at here, for 2013 and 2014. As you can see, chlamydia goes up yearly. In 2015, the preliminary data that we have, which I didn't publish here because it's preliminary, probably around 30,000, a little over 30. So every year, chlamydia goes up, and it's prevalent among young people, women of childbearing years, age 29 and under in New Jersey. Across the country, it's 25 and under. Infectious syphilis has been going up the past couple of years, And in 2014, we had 297 cases of infectious syphilis, which would be primary and secondary syphilis. Early latent syphilis is out of control. What these numbers are telling me is that we are not catching early cases of syphilis, like infectious syphilis. We're not catching them fast enough. And they're going on to develop early latent syphilis, which in many cases, which we collect data on late latent, we have quite a few people with late latent syphilis. So we really do need to do a better job of interviewing and following up on these patients so we can reach out to their partners and screen in the appropriate places. More than half the gonorrhea and chlamydia cases reported among young people ages are reported among young people ages 15 through 24. 15 to 19 is actually at its peak right now, and that means we're talking about high school kids. And we have been lucky in New Jersey in getting into the schools, really, to address this issue. Prompt reporting is extremely important, and it needs to be accurate. To ensure accurate analysis of data, to ensure funding in this, is distributed in disparate populations and communities. It also is important for us to do the appropriate, give the appropriate communities or targeted for appropriate screening and education, extremely important, to determine basis upon which to plan and evaluate an effective program. If you don't know where your disease is, how are you planning to address it? To justify the request for state and federal funding, we need to know where disease is and be able to let our grantors know where we're targeting. And also to ensure patients are located swiftly to provide appropriate care and to stop the spread of disease. Very important. STDs can get out of control very quickly. The Affordable Care Act has significantly increased the proportion of insured individuals and has shifted some vulnerable and at-risk populations that traditionally part of the STD safety net service, those ones that come into our STD clinic. They're now going to other providers. They, go to primary care providers and mostly in patient-centered medical homes. A part of the STD program's responsibility is to determine where at-risk patients are receiving safety net services and identify the clinical and prevention service gaps for at-risk individuals who are receiving care, which means, and the reason I'm pointing this out is we have 8 DIS in the field right now and 3 supervisors. Their time is split between providing the technical services to our STD programs and our private providers, because for the most part, private providers do not see STD cases, and so therefore we do need to keep an eye on that and make sure that they're addressing those diseases properly. Now, to ensure there are no missed opportunities by the providers, including safety net providers, the STD program has been reaching out to facilities that service at-risk populations to ask for assistance with monitoring screening rates. The majority of STDs are identified through routine screening rather than through symptomatic or diagnostic testing. It is very important to target your populations that are disparate for screening. Therefore, monitoring or screening rates is really, really important. At a minimum, all STD programs must include the following monitoring activities: measure annual chlamydia screening rates among young females 15 to 24, enrolled in Medicaid programs and seen in Title X and other family planning clinics. Measure annual syphilis and rectal gonorrhea screening rates among MSMs seen in high-volume, high-care settings. in jurisdictions with congenital syphilis, which we don't have right now, measure screening for syphilis among pregnant females in prenatal care and birthing facilities. Public health STD services currently are primary prevention services, which would include interviewing and partner referral, epidemiology, disease intervention services, which means that if you locate a sexual partner, even if the partner is not positive, that person needs to be treated immediately to prevent them from getting disease. Outbreak response, each program really do need to have an outbreak response plan. Many programs do not have that. It is very important that you identify the people that will be addressing an outbreak so that it doesn't get spread any further. Laboratory services, targeted screening, very important, targeted populations. You need to target them for screening so that you can catch disease. Rescreening, also important, especially for gonorrhea, and to follow up to make sure that that person has referred their partner for treated and they're not reinfected. Or if there is no resistance, because right now we have resistant gonorrhea. Assurance of access to service. Every STD program needs to have access to service. They need to have a clinic, either that they run or a clinic that they contract with, so that their residents in their jurisdictions can go to these providers to receive service. Extremely important. We've had many questions recently about changes in our program. For those of you who are concerned, and if you've heard rumors or whatever the case may be, we have been working very closely with our STD clinics and our STD programs over the years. We have really good partnerships, and we communicate with our partners out there. If there have been any changes that affect your program, you would hear from us. You would either hear from my office, or you would hear from our DIS staff or their supervisors that are out there running around in their communities. They would let you know if there is an issue. If you do have a concern and you have questions for me, you can always reach me via email. I run around the state a lot, so I'm not at my desk a lot of times. So if you do need to reach me, and if you do have specific questions about your program and how any changes might be affecting your program, not somebody else's program, your program, contact me and I will let you know. If you do have any questions for me, please don't hesitate to reach out. No questions?
Did you want to, here's a question, what is the responsibility of a local health department without an STD clinic in relation to case investigations or outbreaks?
Okay. If you have a public health program in your jurisdiction, and this is according to Title 8, Chapter 52, if you have a public health program, which includes STD, you need to either have a clinic or you need to contract with one so the residents of your jurisdiction have access. It's not the state's responsibility to provide that.
Okay. There's a question specifically about Monmouth County and maybe some changes in Monmouth.
Well, as I said before, we have DIS staff in the field that do provide some direct service, and they do assist programs that don't have DIS or field investigative service very quite frequently. In Monmouth County, we recently had a retirement. Somebody retired, and as you're all aware, the state has not been hiring. You know, there's been a hiring freeze in place, and hiring is slow for the most part, and so on and so forth. So the person that was in Monmouth retired, and so therefore there's a gap. There's a hole there because Monmouth County does not have a field investigator. We were led to believe in the beginning that someone is being trained to do this job, and we actually put that person through training because that person was referred to us by Monmouth for training. We sent that person through the partner services training and was grooming her for this position, and she has since resigned or left Monmouth. So we are strapped because we have been helping. We do not allow services to go by the wayside. We actually do send people out because we do monitor positivity through our CDRSS system. We look at where disease is and what priority cases are there, and we help to follow up on it. But right now, we have people, believe it or not, coming all the way from Patterson or from Newark, running around in Monmouth. So Monmouth County needs to hire a field investigator or DIS.
Okay. An additional question, are FQHCs considered to be STD public health clinics, and if so, is a contract necessary?
No, they're not STD public health clinics. FQHCs are federally qualified health centers. And yeah, they can, because I do know a few FQHCs that that provide STD services. Believe it or not, Newark is currently, or they became an FQHC maybe a year or two ago. So yeah, it does happen, but not necessarily. Some health centers are not, like I said, they don't see STDs a lot, and so therefore what we've been doing is partnering with some of our facilities that don't normally provide STDs and trying to provide them with the guidance and the guidelines that they need to provide follow-up and care for STDs.
Okay. Another question, have PEP guidelines regarding resistant STD treatments been provided to resident physicians and ER doctors?
No.
Okay.
But, the guidelines are at the CDC website on, treatment and care for STDs. So that's something, because, we have been, there are 8 people that we have out there. That's what we're doing now, reaching out to private providers and providing them with the guidance that they need to provide the appropriate care for STDs. It's an arduous task and very difficult, and so that's why we're not available anymore at a whim to provide services that the local programs are supposed to be providing for their residents.
Okay. Question, can Planned Parenthood perform the STD clinic function?
Some have, yes. And we have a very strong partnership with the Planned Parenthood because the very population that we target for screening go through these facilities on a daily basis. And so they are targeting the age group for screening, and they are following up with them to come back for treatment if they were asymptomatic in the first place, and they're following up on their partners. So yes, the answer is yes.
Okay. How about counties that have more than one local health department? Is it the county health department's responsibility to cover the entire county in that scenario? We don't have
the STD program, our STD program, we don't have jurisdiction over that sort of thing. We find local programs that are already in place, and we establish partnerships with them and provide them with the guidance that they need. That would be a question for the Office of Local Public Health, who does regulate that sort of thing. We do not regulate.
Okay. One person is thinking of starting an STD clinic. Where could they find out more information on how to do that?
That's a good question. Send me an email real quickly, and I guess my email will go through as is up there because we haven't switched over to Outlook yet. So it'll come through. Send me an email, and we'll definitely find out for you and see who you need to talk to get started. That's a good question.
All right. Are we responsible for CDRSS entry on positive STI cases?
Positive STD cases are to be reported to the state Department of Health electronically, and that was something in 2011. It became a requirement that reports come into us electronically. Some providers are still faxing to us. We do accept faxes, but it makes everybody's life a lot easier, and it frees our staff up a lot more to be able to assist everyone out there if it comes in through CDRSS. If you do not have access to CDRSS, you do need to contact us so that we can make sure that you're in. It makes it a lot easier to report, really.
Okay. Is there a list of STD public health clinics in New Jersey available?
Yeah. We do have, we try to update that regularly, but people need to let us know when they move. They really need to send us an email to say we've moved, or we've changed locations, or we've moved to a separate floor, whatever the case may be. But yeah, we do have a list of all of our clinics that provide STD services, not necessarily STD clinics, but that provide STD services, which include STD clinics. And, if you go to the website and you pull that list and you see your clinic there and the information is wrong, you do need to let us know that so we can update it. But yeah, we do keep a list of that on the website.
Okay. I'm going to take one final question. We do have more questions here. I'm hoping we can get to some at the end. But the final question before we go to our next speaker is the training that you were mentioning that's provided to local health departments with the New York Training Center. When will the next one of those be?
There is a class coming up in New York City starting somewhere in June. It has not been finalized yet, but my understanding is that they have a class coming up. Someone from Morris County also has been communicating. We gave her the link to the New York City Training Center, and she has been in communication with them to see if she could bring them here for, to her facility for training. And those are the only two that I'm aware of right now. But if you are interested in getting someone trained to provide partner services, do feel free to contact myself or Amelia Hammerman, and she will be able to provide you with additional information on what you need to do for that.
Okay. All right. Thank you very much, Patricia. Again, we're going to try to get to some of these other questions at the end. And if not, again, I will provide a list of those questions to Patricia, and she can respond to you directly. For right now, I'm going to turn it over to Jason Mayer. He is our Healthcare-Associated Infections Coordinator, and there has been an awful lot of activity gone on in this area in the past couple months, and Jason's going to speak to us about some of those responses.
Okay, thank you, everyone. So I just wanted to talk a little bit about some of the activities that we've been doing on the healthcare-associated infection front at the State Health Department. We're calling this group of activities that we're doing infection control assessments and response, and the reason we're calling that is because we've got grant funding from CDC, and that's what they're also calling it. We like to lovingly refer to it as ICAR. So if you hear me refer to ICAR as we go through this presentation, that's what I'm referring to. It's these infection control assessment activities. So this first slide is just my public service announcement for healthcare-associated infections. There's been a lot of focus on the continuum of care throughout the healthcare spectrum, and CDC especially has put a lot of emphasis on the relationships between the healthcare facilities and how patients can transfer easily now from acute care to long-term care to maybe ambulatory care facilities or other private health outpatient home care facilities. So within the activities I'm going to be talking about, there are targeted assessments for each of these types of facilities, but I do want you all to keep in mind that there are basic infection control tenets or activities that really span all types of care, and those really are, safe injection practices, good hand hygiene practices, and just in general the separation of clean from dirty processes. So these are all areas that we're going to be talking about going forward, and really are at the heart and soul of the infection control assessments that I'm going to be talking about. So just a brief background, and I don't want to get too much into the nuts and bolts of how these activities sort of came about, except that after the Ebola crisis that sort of hit, past October, CDC had pushed out funding through states to perform infection control and infection control capacity activities that basically were to prepare states to get involved in the next big activity or the next big emergent pathogen that comes out, not necessarily Ebola. In fact, throughout all of our activities for this Ebola grant that we got, we only had one specific assessment group that was specific to Ebola facilities, which I'll talk about later. The rest are general infection control assessments that really don't have as much to do specifically with Ebola, but with general infection control practices. So, the basis of the funding that came out was really to enhance the infection prevention across the healthcare continuum, and also to build a sustainability for improving infection prevention in the state. And that really comes into identifying infection control gaps and helping facilities facilitate their gap mitigation. And part of that, later on, which, we can get into in later webinars, if, I can always come back and talk about once we have some of these activities more in place, but how can we sustainably build infection control throughout the state? And part of the mindset for that is incorporate into potential trainings and education sessions for facilities. So our funding really came in two distinct bunches. One, which was Activity A, really focused on our Ebola hospitals. We also had supplemental activities for creating healthcare inventories for all the facilities in New Jersey, and that really includes who are the infection control contacts at all these facilities, what's their HAI data capabilities, can they report outbreaks, do they know how to report outbreaks, things like that. So as you're going to see, I'm going to break down basically the amount of healthcare facilities that we know of in the state right now, but it's a lot of facilities, and it's really a big task. So that's something that's really ongoing. I really haven't touched on it as much in this presentation, but hopefully can get more information for you guys later. Activity B is really the expansion of our infection control assessments to other hospitals and healthcare settings, and that's really what I'm going to be talking about on top of the Ebola hospitals. And as Kim had pointed out at the beginning of this webinar, we did get some new staff to come on to help us do some of these activities. Patty Barrett, who's being transferred to a different role now, but she was working on this, and Bridget Farrell as well. So what are the type of facilities that we're planning on assessing or have assessed so far? So the big three assessments that we just actually completed last week are the Ebola designated treatment and assessment hospitals. So we have one treatment hospital in New Jersey, and we have two Ebola assessment hospitals. And I'll get into a little bit later about what sort of went into those assessments. There's also the general acute care hospitals, or what they call frontline hospitals. There's 68 of those. Long-term care facilities, obviously we have a lot of those in the state, or almost 2,000. Hemodialysis facilities, we've already begun doing our assessments on outpatient hemodialysis facilities that we will talk about in a little bit. And sort of the big elephant in the room are the outpatient care facilities. As you can see, they make up by far the most healthcare facilities in New Jersey. They are sort of a lumping of all different types of facilities, to ambulatory care, to dental facilities, to private physician facilities. Some of these facilities aren't licensed by New Jersey, by the state health department. So getting at some of these facilities are a little difficult, and that's why that inventory is going to be so crucial to some of our efforts. So obviously, needless to say, not all of our facilities in New Jersey are going to be assessed. We're going to take a sampling of each of the facility types, hopefully, and depending on our resources, be able to see how many we can get at through our assessment. So how are these facilities going to be assessed, or how have they been assessed in the past? So what we use is a CDC standardized infection control tool that's specific for each setting. So there's a setting-specific tool for the Ebola hospitals, for the acute care frontline hospitals, for the outpatient hemodialysis facilities, and for outpatient facilities in general, and long-term care. So there's different CDC assigned tools. Some of those tools, what they involve is more of a talking-based tool where you're doing an interview with whoever's in charge of infection control at the facility, and then another part of the tool generally revolves around doing standard observations for healthcare practice. So depending on the facility and depending on how large the facility is, what kind of practices they have, the staff that will be going in and doing these assessments varies. Generally, what we've been doing is including part of the HAI infection control team, which include our epidemiologists and infection control specialists, and then we supplement that with other team members that can be comprised of the local health department where the jurisdiction of the facility resides, regional epidemiologists at the state health department, and other experts if we have areas that need to be tackled. And that is mostly from our Ebola assessments, and you'll see the different domains that we had to cover for that. So for occupational health, environmental health, things like that. After the assessments, what we've been trying to do is build a relationship with these facilities. It's not meant to be a one-off with these facilities. We're trying to have a sustained relationship with them. There's two different types of really gap mitigation that for infection control purposes that we're talking about. One is that sort of direct on-the-spot education and gap mitigation, where we see a practice or a clinic has a problem and needs to be addressed. We'll talk about that with them directly and sort of get that gap mitigation ongoing right there. And then there's others with facility updates. Now that could either be follow-up assessments, that could be conference calls with facilities, where we sort of give additional focused resources based on our assessments. So there's different layers of follow-up that we want to do after these assessments. So what I'm going to talk about next is what we've done already, and what I want to start with is our most recent set of assessments, the Ebola designated hospitals, and this was really a big task for us. The Ebola hospitals, we have one treatment facility, as I said, Robert Wood Johnson, and two assessment facilities. They have a specialized role. They have more focused resources to take care for these Ebola patients and really to gear up for the next big emergent pathogen that comes in. And really the difference between the treatment facilities and the assessment facilities is sort of the length of care that they're expected to be, caring for these patients. So the treatment facility is really supposed to have this comprehensive, really lengthy care, and the assessment facility is more for care and isolation only during diagnosis, and then upon diagnosis, hopefully they can ship that person out to the treatment facility. So what we really had to go in and do is assess the readiness of the facility. So can the healthcare personnel provide safe care during Ebola assessment and treatment? And that involved doing on-site assessments, looking at some of the policies, procedures, training materials that they had, any sort of supplies. What we did was also take a tour of the facility and also had them do a PPE demonstration to sort of show what their entire operation was for donning and doffing their PPE. And that, that process could take up to about 40 minutes for each, at least for the doffing process. So it's a lengthy thing. They all have checklists. It's very standardized. So these things all had to be sort of looked under a microscope. And just for the last bullet, this wasn't the first time these hospitals have been visited by either state or federal teams. Early in the process when Ebola hit, CDC went to go visit some of these facilities to do general Ebola designated assessments, and our assessment tool that we were using for the Ebola hospitals were basically the same tool that was just basically updated a little bit to include some of the more pertinent information. So, these facilities have already had people come in and do these assessments. So I don't want to labor on what exactly these different domains sort of incorporate, but as you can just see that there's a wide variety of things that we had to look at and basically take into consideration that we at the Healthcare and Associated Infection team really don't have as much expertise in, say, something like waste management, so we had to outsource our experts and be able to get other people involved. Our teams that went into these facilities all were about 13 or 14 people, and that's a large group to sort of go around and take care and do tours of the facilities. So it was cumbersome to say the least. So our treatment hospital assessment was done on January 7th and 8th. That was a 2-day assessment. We actually benefited by having faculty members from the National Ebola Training and Education Center, which is NETEC, abbreviation for NETEC. And what they really are is faculty from either Emory, Bellevue, or the University of Nebraska. And they have staff from their hospitals come in and do assessments and are able to sort of give that on the ground real world experience from what they had when they treated Ebola patients. So they were able to give our treatment center, I guess, a really good assessment, and we were able to also learn from them. Our other 2 assessments were conducted January 12th and 14th, and because they were just assessed, we don't have the summary data and data analysis, but we're working to put that together now. So our other big assessment were our outpatient hemodialysis assessments, and some of the brief background is we've had a couple, more than a couple actually, hepatitis C seroconversions over the past 2 years. There's been 16 cases and 9 unique seroconversion facility investigations. Part of that has to do with some of the screening requirements for New Jersey, but there's also a pretty good focus on hepatitis C surveillance. So what we wanted to do was do hepatitis C, outpatient dialysis assessments of these 9 facilities, and we conducted those in October. So we placed our initial calls to the facilities, and we were able to follow up with some written documentation, just sort of outlining our goals and figuring out how we wanted to conduct our assessment tools. And we distributed these tools with the facilities before we even came in. So we really wanted to build that trust with the facilities and have them know what we're looking at when we go in. So our site visits for each of these facilities took about a day and a half, with one exception. One of the facilities only saw patients on Monday, Wednesday, Friday. And basically our outline for our visits was we wanted to sort of state our purpose for being there, and the general way we were going about looking at our infection control assessment tool was observations and interviews. So we would have part of our team conduct interviews with the staff that were in charge of infection control, and the rest of the team did observations. And the observations went for pretty much the whole first day and that little bit of the second day as well. For the infection control assessment tools in general, there are observations built into each of these tools, but for dialysis, by far, they rely more on the direct patient care observations more than any of the other tools. So, it can be intimidating at first. We had to sort of get our staff ready and prepared to do these observations, but I think everyone was pretty comfortable by the end of it. And we did a short brief exit how to give our feedback for the facilities. And we're still in the process of reaching back out to our facilities to give some more of our final results. So just a brief summary of some of what we did for the site visit. So the team visited 9 facilities over 2 weeks, and as you can see, a lot of observations were collected, almost 3,500 observations, by the vast majority of which were hand hygiene observations. The rest were the different, the different steps within the dialysis process, and some medication preparation and administration. So I'm going to go through some of the results that we have found so far. So each of the observation tools for CDC has a list of steps that the facility has to complete successfully in order for it to be considered a successful observation. So in the example of catheter connection and disconnection, there's about 10 steps that each of these facilities have to do in a row that has to be done correctly in order for it to be a successful observation. If they only get one of those steps wrong, it's considered a non-successful observation. So some of these numbers look pretty low, but as you'll see in a moment, there's a reason for that. Sometimes they're only missing 1 or 2 steps, within the process. So if we dig a little deeper, I think we're going to go into the catheter connection. As you can see, most of these are the different steps that the facilities have to do in a row to be able to be considered a successful observation. Some of the problems that we found was the hub antiseptic wasn't allowed time to dry. The facility staff would just rub the hub. They would scrub the hub, but then they wouldn't allow any time for it to dry before connecting. And also there was an issue with connecting the bloodlines aseptically. Sometimes they would, before connecting the bloodlines, they would go touch the machine or touch the keyboard by the dialysis station. So those two were our biggest issues, and the rest of them were conducted fairly well, over 89% for the rest of the steps. But because of this, the low success rate of 36% through essentially 9 facilities, it's a little alarming, and these are also based on CDC best practices, so to keep that in mind as well. Again, for catheter disconnection, the hub antiseptic not being allowed time to dry before when they're scrubbing the hub on disconnection, and the rest of the steps done fairly well, over 88% of the time, but again, low success rates in total for catheter connection and disconnection. For AV cannulation of the fistula, basically over 85% for every one of the different steps that we had observed, but the actual success rate for the total observations for cannulation was only 63%. So, you get, again, once you get one of these steps wrong, it's not, it's going to hurt your overall success rate. So what we wanted to do with getting back to facilities, give them this level of data where they can see what exact steps they've gotten wrong and be able to sort of focus on those specific steps. Because just telling them overall you're doing a good job only 36% of the time isn't too helpful for facilities. They really need to see what steps in the process they're missing in order to sort of focus their efforts. And also to know that, you guys really are you're doing 9 out of 10 things right, but you really need to focus on this one thing to get your rate back up. So for routine disinfection of the dialysis station, we expected there to be some issues here. Our colleagues in healthcare facility survey and evaluation really have highlighted some issues that they found in some of the routine disinfections of the station, and we found it too. Basically, sometimes the station isn't totally empty before they start cleaning the station. Sometimes there's an issue with applying disinfectant, the bleach solution, to all surfaces and the prime bucket within the station. So these are honestly issues that we expected, and it's going to be a challenge. A lot of this, because dialysis is such a fast-paced environment, it's really getting them to think to slow down, to take their time with some of the routine disinfection of the surfaces. So it's something that we're going to focus on in the future. So as I said before, the follow-up for our dialysis facilities, we're really looking to give them back a report with these observations so they can sort of see exactly what they're missing, and also to establish conference calls with the facilities. So just briefly, what's next? We have a list of facilities that we need to target. We need to target more long-term care facilities, acute care, and outpatient facilities. And that's the outpatient facilities is really the question of where are we actually going to target. There's outpatient oncology facilities, as I said, oral surgery, dentist practices. There's a whole group of facilities. So we have our work cut out for us. So if anyone has any questions or any follow-up comments or questions I can address today, I encourage you to reach out to me. These activities are going to be ongoing over the next couple of years, so this certainly won't be the last you'll be hearing from us on it. Thank you. Okay.
Okay, so I know we're running a little bit late, so we'll just take a few questions. I do want to say that I have many questions here for Patricia related to STD, and I know we're not going to get to all of them, so I am going to print these out and give them to her, and she can respond to you directly. A couple quick questions. There was one, Ellen, on where people can find the updated case definition for hepatitis C.
So you currently have the current case definition from the slides. I'll put it in the typical presentation and send it out via the EPI program, and then an updated Hep C revised chapter, including special populations and healthcare settings and how to investigate them, will be coming out via a links message in the near future.
All right, thank you. Lisa, one question for you. Are swabs available from the state lab for respiratory outbreak response?
So the answer is yes and no. We have supplies at the state public health lab. We have limited funding to purchase those supplies, and the intention is not necessarily for outbreak response. But if you're a local health department and you're involved in an outbreak response and you are not able to obtain them through traditional laboratory testing, for example, through a long-term care contract, if they're occurring somewhere else and you have someone who is willing to do nasal swabs, we can certainly work with you to try to get those swabs to assist in that outbreak. Just contact your regional epidemiologist or myself, and we're happy to help with that.
All right, thank you. One thing about, in relation to the questions for STD, I did have a comment received in from Natalie Palenko, and I wanted to share that with everyone. She did say that the authority, responsibility to provide STD services resides with each health department, and a health department can contract with another to provide those services. So a county health department does not have the responsibility to provide the services countywide if there are other local health departments in that county. That was a comment from Natalie Palenko, so I did want to share that. And there was a question if the questions and answers on the STD program, if Patricia maybe could provide that to attendees. If she'd like to, develop that, I'd be happy to send that out. And again, I apologize, but we're not going to get to the rest of the questions. Real quickly here. Okay, just to wrap up. There's a couple upcoming trainings. I'm not going to go over these. The forums are coming in April. There will be a statewide Legionella conference in May that some of you may be interested in. And in June, there is a drug diversion conference. So I have the information here on the slides. In terms of evaluations, anyone who has, quote, attended will receive a link to the evaluation. So if you are registered under your name on GoToWebinar, you're counted as attended. If you watch the webinar as a group, I need a group sign-in sheet that contains the name of the webinar, today's date, your name, signature, organization, and your NJLMN email address. And if you want to scan and email that to me, that's best. I put my email there. If not, I included my fax number. And that way I will count you as attended, and then you'll all get the evaluation link. The evaluation will be active for about a week. And if you're receiving public health credits, those will automatically appear on your NJLMN transcript. For nursing certificates, make sure on the evaluation you include your name and email, because that's how we're going to email your contact hours certificate. And that may take a couple weeks, but it will get to you. And with that, I'd like to thank everyone for joining us today. We know your time is valuable. And again, we'll definitely make sure to get those remaining questions out to everybody. So with that, thank you very much.